Welcome. I'm Dr. Fernando Pagán, Professor and Vice Chairman of Neurology and the Director of the Movement Disorder Program at MedStar Georgetown University Hospital. Welcome to the Advanced Therapeutics in Movement and Related Disorders Congress. We're very excited about today's program. You'll notice that our lectures are based a little bit different, but one of the things that we really want to talk about today is our therapeutics. So the first lecture is Not Your Grandmother's Dopamine. We're going to talk about the advances that have been made over time. We're talking about the dopaminergic therapies in Parkinson's disease, but throughout the whole entire course, we're really going to be talking about the clinical trials and what have led to advanced therapeutics in movement disorders, and especially with Parkinson's disease will be the highlight of in this particular one. We hope to be able to do this in the very near future live. But for the first one, we'll be virtual because of the Delta virus, but hopefully in the future, again, we plan to do this live, much more thorough, more in person. I think we'll get a lot more out of it that way. But for today, we'll start with the highlights of this advanced therapeutics in movement and related disorders. And again, there are some great courses on pathophysiology and phenomenology. So we're assuming that you already know how to identify the different types of movement disorders, especially the most common one that we treat, of course, is Parkinson's, but really highlight the therapies and what advances have been done in therapies, and also give a little hint of what's coming to the future. So today, what we'll talk about is the management of Parkinson's. We'll definitely talk about how to provide symptomatic relief, how to reduce the functional disability of our Parkinson's disease patients, and we'll talk about how to manage motor fluctuations, dyskinesias, wearing off, etc. And then, of course, the holy grail is trying to find something that ultimately slows down disease progression, or quote unquote neuronal protection. And there's a lot of great research being done. And again, that can definitely be done more in the future as we see these therapeutic trials looking for disease modification. And I think we will see a lot more disease modifying trials and a lot more disease modifying therapies that will be tested over this next decade. So let's take a look at the clinical decision making in Parkinson's disease. So really what it is really taking a look at the patient. We have to see what each individual patient is suffering from. And again, we'll talk a lot today about how Parkinson's is both a motor and non-motor disease, but looking at the impact on the functional livelihood of that individual. So looking at the functional impairment of each individual patient, looking at how that affects their quality of life. That really is what overall is the disease severity of that patient. And depending what the disease severity of that patient is, that's how we're going to choose our therapeutics. Also taking a look at any comorbidities the patient may have, the age of the patient, any types of drugs that they've tried in the past that they may not be able to tolerate certain drugs, and also looking at how well a patient is going to be able to adhere to these medications, and also the risk of long-term complications like wearing off and dyskinesias, etc. We have a lot of treatment options available in Parkinson's, and I hope that's what you get out of this particular lecture, all the different types of treatments. And I'll start off by saying one of the things that I see pretty much on an every weekly basis when I meet a new Parkinson's disease patient is that they've had the disease 5, 10, 15, 20 plus years sometimes, and they've only been offered one treatment. So that's what we're going to really talk about, all the different available treatments, and learning how to use these particular treatments, I think is going to be essential in giving our Parkinson's disease patients the best quality of life possible. And again, there's always something we could do for them. And again, looking at all the different therapies and how they potentially could be beneficial for a Parkinson's patient is going to be what is so essential in treating Parkinson's over the long term. Unfortunately, we don't have any preventative treatments yet. There's, again, a lot of research, hopefully not only potentially preventative, but hopefully we'll have true disease modifying treatments. I really am very hopeful that there are a lot of treatments currently being looked at, and hopefully within this next decade that we will have disease modifying treatments. We've already seen one particular one be already FDA approved in the most common neurodegenerative disease Alzheimer's disease, with using these antibodies against these antibodies against beta amyloid. Again, a lot of controversy with it, but hopefully we'll see further treatments in neurodegenerative disorders and a lot more robust research, hopefully within this next decade. So we're really going to be talking about symptomatic treatments today. We have a lot of pharmacological and surgical treatment options for the symptomatic treatment of Parkinson's disease. This particular lecture, I'm really going to talk mostly about the levodopa-based products. And again, this is not your grandmother's dopamine. Again, I'll get you through the history of the dopaminergic therapies and how we've evolved, that how we used to treat things in the 1960s, 70s, and even 80s. Things are changing pretty drastically. A lot of times I meet patients, again, they've only been ever offered one particular treatment, and it was like we were treating Parkinson's back in the 1970s. Surgical treatments involve mostly deep brain stimulation. We also have some drug delivery systems as well. And again, that's a whole other lecture that we can give. I'll stick mostly with the pharmacological treatments in this lecture, especially the dopaminergic pharmacological agents. Non-motor management is also very, very important in the treatment of Parkinson's, and we're getting better and better with the non-motor symptoms of Parkinson's disease. And that will be a different lecture that you'll hear today as well, or tomorrow. And then restorative, again, these have mostly been experimental research, transplantation, fetal cell transplants in the 1970s, stem cell transplants are still being talked about, and then neurotrophic factors like GDNF and BDNF, which increase naturally with exercise, but a lot of research still being done in this arena. Again, this is still very hopeful for treating Parkinson's disease and also maybe potentially having a disease-modifying benefit potentially in the future. But again, this is still under a lot of research and no FDA treatments are currently available for this. Let's take a look at the different drug classes we have in Parkinson's. So we're going to talk about the dopaminergic agents mainly in this particular lecture. So the dopaminergic agents are levodopa and dopamine agonists. So levodopa is the precursor for dopamine. And again, this has been really the mainstay. And in the 1960s, early 60s, intravenous levodopa was available. Then it wasn't really till late 60s that oral levodopa started being able to be used, and then combining together with other different agents to enhance the bioavailability of levodopa and get it through the blood-brain barrier. That's when we really start to make a difference in the motor symptoms of Parkinson's disease. Dopamine agonists mimic the effect of dopamine. Again, we have a whole group of those particular type of treatments available. Then we have other agents to extend the activity of levodopa, like CL-methyltransferase inhibitors. These prevent the breakdown of the COMT enzyme, preventing the premature conversion of levodopa to 3-O-methyl-dopa in the periphery. And we have several agents that do that as well. That will be covered in our levodopa extenders lecture. We have MAO-B inhibitors that prevent the breakdown of dopamine. And again, the monoamine oxidase B enzyme will break down dopamine in the central nervous system. And by doing so, you produce dopac and hydrogen peroxide. By inhibiting this particular enzyme, you're able to reuse and recycle endogenous and exogenous dopamine, either made naturally by the body or made because you gave a drug like levodopa. So it definitely is one of the drugs that we use extenders, and there's a lot of benefits potentially to that particular drug as well, those particular classes of drugs as well. Then we have medicines like anticholinergics that block the indirect pathway that are very good for tremor control, but there are issues with using these type of medicines. There's also the amantadine-based compounds that have NMDA blockade. They also have some anticholinergic properties. This is a whole class of drugs by itself. And then our newest class of drugs are the A2A antagonists. This is one of the drugs, istradefylline, that recently came out and has been in Japan for at least 8 or 9 years now. The A2A antagonist is a relatively new drug for us here in the United States to be able to enhance the activity of levodopa, increase on time, reduce off time, and that will be also covered in some of our other lectures. So we have a lot of drugs available, and a lot of activity has been going on with understanding how Parkinson's occurred when it was first described in 1817, all the way now. We're seeing new classes of drugs or reformulation of some of the old drugs to enhance the availability of dopamine, whether centrally or levodopa peripherally, et cetera. And that's what these lectures are going to be about, to really go in depth into all the different drug classes and hopefully get a better understanding of the therapeutics that are available in Parkinson's disease. So back in over 200 years ago now, so James Parkinson's described in his essay of shaking palsy 6 cases. 3 of them were patients observed in the streets that he saw walking by. 2 were only actually his actual patients. But he first described what we now call Parkinson's disease in this essay, Shaking Palsy, back in 1817. And look at what has happened since 1817 over the past 200 years. A lot has happened. And we now even have arguments about what truly is Parkinson's disease. So we've learned that it's more than just one condition. And there's multiple types of quote unquote Parkinson's or Parkinsonisms, et cetera. Sir William Gowers also had a manual of diseases of the nervous system, and there he described 80 patients in the 1880s with tremor, rigidity, bradykinesia, and postural instability. So he talked about how these patients looked and described them in working in London at this particular time. And for the tremor, he used hyoscyamine and also noted that arsenic, morphia, hemlock, and Indian hemp were very effective agents for temporary tremor abatement. So even in the late 1800s, we were seeing other people also kind of describe what James Parkinson's originally described in 1817 in his essay of the shaking palsy. Then was Dr. Charcot, also in the 1880s, 50 years after James Parkinson's described it. He pretty much took a look at this and he said, wait a second, this term, shaking palsy or paralysis agitant, that really doesn't describe what is happening here in these individuals. And he was the first to suggest to call it Parkinson's disease in honor of James Parkinson's essay of the shaking palsy. But he also described distinctive features of his patients, looking at the forehead muscles, of that lack of facial expression, taking also a look at some activations of the frontalis muscle, et cetera, that are seen. It's also interesting that he noticed that some of his patients who will come into town either horseback riding or after a carriage ride, that they just seem more rigorous as some of the patients who just had short distances to walk in the city to come see him, but the patients who came from farther away tended to do a little bit better. So he developed a vibratory chair and a helmet to try to see if he would vibrate patients. Would this be beneficial for patients to get them walking a little bit better? But again, this is one of the things. So even back then, Charcot realized that patients who were more active and he didn't really notice at the time, but they were exercising. The more activity a patient had, the better off that they were doing. And some of these patients who did have to prepare their horse, get on horseback, ride into town, those patients seem to do better than the patients who didn't have to do all those things or get ready for a carriage ride there. Maybe there was a travel benefit, et cetera. So he tried to devise this chair. It never really worked, but this is kind of what we've tried to do all the time. We always try to mimic the effects of exercise, but definitely exercise has been one of those things that we see in Parkinson's that continues to benefit our patients, maybe have true disease modifying benefits. That increases our GDNF, our BDNF, these field-derived nerve growth factors, these brain-derived nerve growth factors, these endorphins. Our patients just feel better. They move around the better that they are. And, in my clinical opinion and what I see with our Parkinson's patients, the importance of treating them is so that we can keep our patients feeling better, keep them moving. And the more they can do, the more they can exercise, that within itself has a disease modifying benefit. In fact, research has shown that the life expectancy of Parkinson's disease patients before levodopa-based medications were available was well below that of the general population. But once we got levodopa-based medications and we started treating Parkinson's disease, now our Parkinson's disease patients had the same lifespan as that of the general population. So in my viewpoint, we have had disease-modifying benefits with our medications for Parkinson's. So it's important to treat. And I'll show you that. I'll show you some slides later on with some of the research that we've learned that patients who are treated end up doing better than patients who are untreated. So it's important to treat our patients with Parkinson's. We've learned that already. And all in all, I continue to meet patients who still don't know that important tidbit of information that Parkinson's patients on treatment do better with Parkinson's patients not taking any treatments. And again, hopefully you can get that message to Parkinson's disease patients that we've learned already that with medications, our Parkinson's patients live the lifespan they were supposed to. It's not shortened anymore because our medicines do keep our patients moving. So here in this particular slide, this is a nice looking slide of all the types of medications that we have available to us. So we have the levodopa-based medications to make dopamine. We have the amantadine-based medications that help secrete dopamine, also block NMDA. We have the MAO-B inhibitors like selegiline, rasagiline, safinamide. We have dopamine agonists. The main ones that we definitely use are Paxil, ropinirole, rotidogene are the main ones that we have here in the US. They're non-ergot derived. And then we have the apomorphine that is available as a rescue drug. And we'll be talking a lot about that particular one in some of the on-demand therapy treatment types of lectures that we'll have as well. We have the anticholinergics like trihexyphenidyl. And then we have the medications that work in the periphery to enhance the activity of levodopa, like carbidopa and benzoyl. Benzoyl is available in Europe. Carbidopa is what we have here in the United States. And then we have our COMT inhibitors like tacopone, entacapone, and opicapone are our COM2 inhibitors. Unfortunately, opicapone is missing from this particular slide. But that's our newest COMT inhibitor. And then we also have a new class of drug called istradefylline. The istradefylline works on the A2A receptors that isn't really shown very well in this particular schematic. But these are our medications. So I talked about when we first make the diagnosis of Parkinson's disease, treatment versus no treatment. So this has been a big question. And a lot of times we spend a lot of times with our Parkinson's patients who just been diagnosed. They have the cardinal motor symptoms. They probably have had some of the non-motor symptoms for many years, but they're worried about taking a levodopa-based medication. Sometimes their symptoms may still be mild, that they may not need a levodopa-based medication, but they may be very appropriate candidates for a dopamine agonist or for potentially a monoamine oxidase B inhibitor. So one of my favorite studies really to talk to our Parkinson's patients and their families about, especially when there's a concern about whether or not they should be taking medication, is looking at this study back by Grosset in 2007. And what he did is he took a look at Parkinson's disease patients who were drug naive over an 18-month period versus patients who were at least given a monotherapy, whether it was an MAO-B inhibitor or dopamine agonist or a low-dose levodopa treatment. And what he saw over time, looking at their health status, the health status of individuals who are at least on a monotherapy was much better than those patients who remained over an 18-month period on no treatment. And you can see the worsening of the health status of those untreated Parkinson's disease period over that 18-month period compared to those patients who are at least on a monotherapy drug. However, when you looked at the Parkinson's disease quality of life subscale, looking at mobility, activities of daily living, emotion, stigmata, social cognition, communication, and just their bodily look, our patients who were treated with a monotherapy, their PDQ subscore was much better than patients who were not treated. So again, this is, I think, a great study to have in mind when you see an early Parkinson's disease patients and you're making a determination. Well, it's the disabilities. Well, usually what we're talking about, initial evaluation, their Unified Parkinson's Disease Rating Scale, Part 3 may be somewhere between a 10 and 18. So you may not even be thinking a high-dose levodopa treatment. But here, sometimes patients, well, I'm not really bothered by it. Tremor is only intermittent. Sometimes I'm rigidity. I'm still able to do things, but it's just slower, But again, if you do nothing over this period of time, or 18 months, you can see that it's only going to get worse. And you can see where if you were to start a treatment, whether it's a dopamine agonist, MAOB inhibitor, or a low-dose levodopa, you can see the PDQ subscore, the Parkinson's Disease Quality of Life subscore, is much better for the patients who received a monotherapy agent compared to patients who received nothing at all. And their health status is much better as well. So I think showing this study, I think, is very important. And sometimes this is what can kind of turn patients around to, okay, they'll accept trying a monoamine oxidase B inhibitor, which it could be just a once-a-day drug, or a dopamine agonist with once-a-day drug, or even starting a levodopa-based medicine, especially if it's warranted. Maybe they have a significant tremor that's bothering them, but their motor other abilities are okay. So I think it's different from person to person. But I think this is a study that you can use to your advantage to be able to talk to your Parkinson's disease patients why a treatment is better than no treatment at all, especially with early Parkinson's disease. We have a lot of drugs that also extend the activity of carbidopa levodopa, and a lot of clinical trials. And when we talk about our on extenders, these are the drugs that extend the activity of levodopa to keep dopamine around a little bit longer, or keep levodopa around a little bit longer, to cross that blood-brain barrier to increase dopamine. These are all the different clinical trials, and we can see that especially when patients wear off, what that means is that medicines are no longer giving them the symptomatic benefits. We want our patients on. And what you can see when we use these on extenders to reduce off time, you can see an off time net reduction about 0.6 to 3.2 hours, depending on which particular study you're looking at. And these were patients who were having somewhere between 3 to 7 hours a day of off time. And these are once patients are already treatment. And we'll have a whole section that will be talking about all these different drugs that can be used with carbidopa levodopa and on extenders to decrease that daily off time in our Parkinson's disease patients. So carbidopa levodopa is still the standard drug for Parkinsonism and for Parkinson's disease. It was first developed in the 1960s, and actually first levodopa was what came available. But you would have to use somewhere between 1 to 2 grams of levodopa. By putting carbidopa together with levodopa, one of the things that happen is that you stop the peripheral decarboxylation of levodopa to dopamine. And when that happens, you decrease nausea, postural hypotension, motor fluctuations, etc. It was very pulsatile. If you ever want to watch what just pure levodopa did and how much you really needed to give, watch the movie Awakenings, when Oliver Sacks gave this first patients with Parkinsonism these medications, and described what happened to these patients. So by giving the carbidopa, you're able to reduce the amount of levodopa from 1 to 2 grams down to 100 milligrams for every 25 milligrams of carbidopa. So carbidopa really helps that nausea and vomiting. In fact, the first trade name of this was meant without vomiting. So although I'm not supposed to say a trade name, but it's carbidopa levodopa is fairly generic right now. The original trade name of carbidopa levodopa just meant without vomiting, Sin-Emet. And that's how the guy's name, Sin-Emet. So this is This is just history per se, but the carbidopa-levodopa was kind of what I tell my fellows and medical students. This was the birth of what we call rational polypharmacy, using small amounts of multiple medicines to help improve our Parkinson's disease patients, whether it's motor symptoms or non-motor symptoms. And we'll be talking about all of these things throughout the course of this advanced therapeutics in the management of movement disorders and other related disorders. So the Parkinson's and related disorders. So again, levodopa, if you can take a closer look at this particular graph, if you can block the conversion of levodopa to dopamine by using dopamine decarboxylase inhibitors, the peripheral decarboxylase inhibitors, this is carbidopa and benzoyl, you get more levodopa through that blood-brain barrier into the central nervous system, and they're centrally acting aromatic acid decarboxylate converting enzymes can convert it into dopamine in the central nervous system. The other drug that we can also enhance levodopa are the acetylmethyltransferase inhibitors, and those are drugs like entacapone, tacapone, and opicapone. So if the CMT enzyme is active in the periphery, it'll change over the levodopa into 3-O-methyl-dopa, again, decreasing the amount of bioavailable levodopa to cross that blood-brain barrier. So these are the different types of drugs that we can use together with levodopa to be able to get them into more of it into the central nervous system to reduce the motor symptoms of Parkinson's. So one of the things that we've learned over time is in the L-DOPA study. So a lot of questions were really still in the early 2000s. We were like, well, how much levodopa? How do we know how much levodopa we give? How do you give it, et cetera? So the standard of care was you give 1 tablet of medicine 3 times a day. Sometimes in early disease, it would start off half a tablet 3 times a day of the 25-100 tablet, or you give 1 tablet 3 times a day for a total of 300 milligrams, or go up to 2 tablets 3 times a day. In fact, I remember once I asked one of our first neurologists who used carbidopa levodopa in this country, asked him, well, how do you know how much you use? He goes, it's easy, Fernando. I give 1 tablet 3 times a day. If I don't like how I use it, I go up to 2 tablets 3 times a day. Then I go up to 3 tablets 3 times a day. Then I go up to 4 tablets 3 times a day. I go up to 5 tablets 3 times a day. And my eyes are wide open looking at him. And he goes, well, and when they get dyskinetic or they pass out or they have a major side effect, then I just back down. Or they hallucinate or they get dyskinetic. I know that's too much. And then I back down. And I was like kind of flabbergasted. So this particular study, I think, opened up our eyes as neurologists. So first thing it did, it took newly diagnosed Parkinson's patients within 2 years who had never taken any levodopa-based medication. And here you can see what the natural progression of Parkinson's disease is. And this is the L-DOPA study. What you see here is if you give no treatment whatsoever over 40 weeks, and there's a washout period for 42 weeks, you can see there's about an 8.5 point worsening in the Unified Parkinson's Disease Rating Scale for patients who are given no treatment over that 6 month plus period. So over that 40 week period, 42 week period. However, if you gave half a tablet 3 times a day, 1 tablet 3 times a day, or 2 tablets 3 times a day, the change in the Unified Parkinson's Disease Rating Scale was much better. They reduced their disability. And the other thing is it doesn't happen right away. You can see it can take up to 8 weeks to see the full benefit of taking that medication, and then up to 6 months for some of the higher groups just to see that. But 6 months later, you can see all 3 treatment groups are well below the baseline, or for the 300 milligram of the 150 milligram group, they're just basically at baseline. So the progression of disease, when you take a look at the slow progression of disease, is much faster in patients who are not treated. Again, we learned this with the Grosset study that we started off with. So this is yet another study showing that treated patients are better off than untreated patients. However, those patients who received the highest dose had a higher incidence of dyskinesia, and wearing off compared to the placebo 150 or 300 milligram group. So again, what I teach my residents and students and fellows is you want to get by with the least amount of medication. So you got to treat the patient. And I think that's the most important thing. So if you go too high in the dosing, again, the higher doses are sometimes you see more motor fluctuations. So again, and this is also given in a very pulsatile fashion. It's just 3 times a day. This was at a time where we didn't know about a more continuous dopaminergic stimulation. And still in the early 2000s or late 1990s, we're still treating a very pulsatile, just like they did it in the 1960s with levodopa. Again, now we're learning a little bit more. And that's why this particular lecture is called Not Your Grandmother's Dopamine, because we're learning about how to better treat patients. And I think it's important to step back and take a look at what we've learned in clinical trials. So far you've gotten down, it's better to treat than not to treat. And especially early on, this pulsatile delivery, especially the higher doses, you see more of these motor fluctuations like dyskinesias and wearing off. So remember that. And you see that'll be a common theme as we start to look at more potent formulations of levodopa in the next couple of slides that will in the future. So the other important thing here, so one of the things that we learned that we keep learning with Parkinson's is more than just a dopaminergic neuronal loss. Definitely we're losing these dopaminergic neurons within the substantia nigra. So these projections of dopamine going from the substantia nigra to different parts of the brain, this is a neurodegenerative process. So what we're trying to do here is we're trying to enhance the dopamine to improve the motor function. But there's other things going on as well. And hopefully through these lectures, you'll learn about all the non-motor symptoms as well that happen with Parkinson's, because there's other neurotransmitters involved like serotonin, norepinephrine, acetylcholine, GABA, histamine, and A2A, adenosine. All of these are very important within the treatment of Parkinson's disease. So what we try to do is get that levodopa up into the brain. And then once we get the levodopa through across the blood-brain barrier using the aromatic acid decarboxylating converting enzyme in the central nervous system, that the levodopa through the AADC will make dopamine. And then the central nervous system, it can be broken down by COMT and MAOB. MAOB is the main one, though, that our Parkinson's patients use to get rid of their dopamine, and that can produce a dopac as well as hydrogen peroxide. So these are, if we can block the MAOB enzyme, then levodopa can be around to be reuptaked and reused in those neurons, like I mentioned before, and that will be talked a little bit further in our on the extended lectures. So we have different types of formulations. We have the immediate release formulations of levodopa, carbidopa, levodopa. So the carbidopa always comes first. So there's a 10-100, and that was traditionally made. We see a lot of internists use that. Start off with the 25-100. We also have a stronger formulation of 25-250. Again, not as much carbidopa. You may see a little bit more nausea and vomiting. You start off with that one. Traditionally, we start off with the 25-100 going. You start a little bit less. We'll just cut in half, use a half a tablet 3 times a day, like was done in the L-DOPA study, and you can continue to go up more. The most important thing is that you'll see an onset, usually within 20 to 40 minutes of giving it. You'll see the peak effect usually at 60 minutes, and then it starts to wane down. We'll show you some of those pharmacokinetics. Most of the time, in immediate release carbidopa, levodopa, you're going to get only about a 2 to 4 hour duration. So the fact that it's traditionally always been labeled as a 3 times a day medicine, it is not. A pharmacokinetic lecture will tell you that is not true. But that's how it was traditionally done. That's how the first individual neurologist did it, and that's why we did it that way. But that's not pharmacological. That doesn't follow pharmacokinetics. So now I think here, more recently, we're paying more attention to the pharmacokinetics of these drugs to be able to really know how to deliver them. The controlled release just delays everything by another hour. But again, the The onset is a little bit more delayed because it's in a wax matrix. It's not a real true controlled release. You get maybe an extra hour of duration, 3 to 6 hours, but it can take up to an extra hour for it to work, and it may not even work. And then we have an inhaled levodopa that will work in about 10 to 30 minutes. It only lasts for about an hour, but this is not for maintenance medication. This is more of an on-demand therapy, and this will be one of the highlights of what we talk about in the on-demand therapies in these different clinical trials. So one of the things that happened in the early 2000s is that we got this combination drug, levodopa, carbidopa, and entacapone. And it was compared to that of levodopa, carbidopa. And what we saw is we really did see a better mean change in the Unified Parkinson's Disease total score for people who received levodopa, carbidopa, and entacapone compared to just levodopa, carbidopa by itself. And in this particular trial, this was the first step. You can definitely, there was first step and there was also stride PD. So we saw that there was more bioavailability of levodopa across the blood-brain barrier. So our patients had better response to the Unified Parkinson's Disease Rating Scale. So a lot of people started to see that these patients look better when they were receiving this. If you were to be able to do a trial using levodopa, carbidopa, and entacapone first, rather than just levodopa, carbidopa, where there would be less of these motor complications, less dyskinesias, et cetera. And some animal studies by Peter Jenner actually showed that. So the next study that was done was the STRIDE PD to initiate the carbidopa, levodopa, and entacapone formulation compared to that just of carbidopa, levodopa alone. But what ended up happening is that the way the study was designed, the bioequivalence of dopamine was much higher in the treatment group receiving levodopa, carbidopa, and entacapone. Therefore, it was actually a failed study. You actually saw more dyskinesias, more motor fluctuations. So at that time, the levodopa, carbidopa, and entacapone was definitely receiving much more favor than just carbidopa, levodopa alone, based on the previous study I showed you. But then now we're seeing more dyskinesias in this particular study. It kind of just fell off the face of the earth when this particular study came out. But definitely, the medicine seemed to be a little bit longer acting. There was better control of the Unified Parkinson's Disease Rating Scale, but had a shorter time to onset of dyskinesias. Therefore, this quickly fell out of favor within the movement disorder group. And then it was also at a time where we saw an oral extended release of carbidopa, levodopa, and this is known as IPX066. And this particular drug is little beads of carbidopa, levodopa that a third of it dissolves immediately. Another third dissolves at 2 hours, and the last third starts to dissolve at 4 hours. So you can see plasma concentrations of carbidopa, levodopa for about 4 to 6 hours. And so this particular drug was even compared not only to immediate release carbidopa, levodopa, but it was also compared to carbidopa, levodopa, and entacapone. And this formulation, IPX066, had better clinical results in these clinical research studies than that of the carbidopa, levodopa, and entacapone in immediate release. What was tricky about it, it wasn't a one-to-one type of conversion. So definitely most of us with movement disorders have learned how to use it. And we know that this IPX066 is longer acting extended release carbidopa, levodopa. These little beads is a 2-to-1 ratio. They come in 95 milligram tablets, 145, 195, and 245s. So the 95 you can have in your mind is like a half a tablet of the 25-100. And the 195 is bioequivalent to a 25-100. And then the peak effect, so a 95 gives you 1/3 of the peak of what you see with the 25-100. To get the same peak of a 25-100, you'd have to give 395 milligram capsules of the IPX066. So it takes a little time to get used to and get the math right. But and again, I think in my clinical opinion, I think a mistake was made also that it was labeled as a 3 times a day medicine. But in the clinical trials, it was given 3, 4, or 5 times a day, depending on where the patient was in the conversion. But there is a very important clinical trial that I think everybody should really be know a little bit about. And it was called the Advanced PD Clinical Study. And these were Parkinson's disease patients on immediate release carbidopa levodopa. They can also be on other medicines as well. But the main way they were being treatment was that they were on immediate release carbidopa levodopa. And the first thing that they happened is that all the Parkinson's patients on immediate release carbidopa levodopa were optimized on their immediate release carbidopa levodopa. So everybody's immediate release carbidopa levodopa was optimized, it was increased. Then after that happened, the next thing that happened is that they went into an open label conversion to immediate release carbidopa levodopa over to IPX066. And that took several weeks. That was done between visits 2 and 5, which is roughly between weeks 2 and 8. So during that time, everybody was converted over to IPX066. Once that conversion took place and they were stabilized, then they were able to open up a randomization. One group of patients were randomized to taking the immediate release, their optimized immediate release carbidopa levodopa, and the other group was continued to take their converted IPX066. And what happened in this particular trial is that there was a reduced daily off time, on average an extra 1.17 hours for the patients who received IPX066 compared to that of the immediate release carbidopa levodopa. So overall, there was about 2 hours more of on time for these patients who received IPX066 compared to that of immediate release. And there was about 3.6 doses per day for the patients on the IPX066, whereas it was much higher for that of the patients who were taking the immediate release. So this was, you saw a greater reduction in off time and improvement in on time. And the immediate release carbidopa levodopa group had a mean number of doses of about 5 doses a day compared to 3.6 doses a day. But again, there's a range. Those are the means. There's ranges. So again, I think what's important from this particular study is that even with the optimization of the immediate release, the IPX066 had less off time, more on time, and less doses. And I think that's what it takes for us as clinicians to learn how to use IPX066, this extended release carbidopa levodopa, and to ultimately find the right dose for an individual. And for some patients, this can make a big difference for our patients to have more on time and less off time. So these are treatments that we definitely have available to us in our clinics. So now we're seeing that another formulation of extended release carbidopa levodopa with a little bit different pharmacokinetic profile. Not everything has been released about the study, but it's called IPX203. And recently we've seen that that there was a multi-center randomized controls trial that evaluated 506 patients with motor fluctuations taking either IPX203 or immediate release carbidopa levodopa, and there was about 0.53 more hours of good on time for patients on the IPX203 in comparison to the immediate release carbidopa levodopa. There's even been that there was showing that there was less off time as well. So we're going to be learning more about this IPX203. This is still just finished the clinical trial. It's not available clinically yet, but at least I want you to take a look at it. And this was a clinical neuropharmacology paper just showing the pharmacokinetics, the plasma just the pharmacokinetics kind of look, or actually the change in UPDRS part 3 of patients on immediate release carbidopa levodopa, the IPX066 or the IPX203. And you can see the IPX203 compared to the IPX066 or the immediate release carbidopa levodopa. The IPX203 had a longer duration of reducing the Unified Parkinson's Disease Rating Scale Part 3, so the motor disability, so more improvement in the motor function of these Parkinson's disease patients who took the IPX203 compared to those other two formulations. So we're going to be learning more about IPX203. So I definitely just wanted to show you this. We just learned that the clinical trial was positive in favor of the IPX203 that was just done in a multi-center clinical trial. I haven't seen everything yet regarding this particular study yet, but I think we'll be seeing more information coming out and looking forward to the publication of this research. Now let's talk about if you deliver carbidopa levodopa more continuous in nature, and probably one of the best ways we have this is through an infusion, and this is called the carbidopa levodopa enteral suspension for short. It's called CLES, C-L-E-S. So the carbidopa levodopa enteral suspension is delivered through, there's a G tube with a jejunal tube inside, and this is delivered continuously over a 16-hour infusion daily. Multi-center clinical trial have done with advanced Parkinson's disease, and what we've learned with these with the pivotal study is that you saw an improvement in off time. You saw an improvement in off time for patients with receiving the carbidopa levodopa enteral suspension compared to those receiving the immediate release oral. And you also saw an improvement in on time without troublesome dyskinesia for those patients who received the CLES compared to the oral immediate release carbidopa levodopa. The mean score increase in on time without troublesome dyskinesia from baseline to week 12 was significantly greater for the carbidopa levodopa enteral suspension than that of the oral immediate release carbidopa levodopa group. And you saw a decrease of off time was approximately 1.9 hours, and the difference for the increase in on time without was also approximately 1.9 hours. So compared to that of placebo. So this is something very important for our advanced Parkinson's disease patients, sometimes delivering the carbidopa levodopa more continuous in nature, and you take away the need to be taking pills orally, especially for our advanced Parkinson's patients that have a lot of absorption issues and the protein interference, the constipation, gastroparesis, etc. Sometimes using this particular pump through the carbidopa levodopa enteral suspension can be very significant for our Parkinson's disease patients. For when our patients do have wearing off, we also have an inhaled levodopa. So it's taking the inhalation of the pretty much pure levodopa, a little bit of surfactants, 99% levodopa through an inhaler when you see the return of Parkinson's disease symptoms. So as soon as an off period is happening, you can take this inhalation. Patients can use it up to 5 times a day. In clinical trials, they average about taking it twice a day. It bypasses the gastrointestinal system. You can see improvement as soon as 10 minutes, and it can last up to 60 minutes for some of our patients. So what we've seen a little bit of a paradigm shift. We have on-demand therapies, we have maintenance therapies, but when we do see these off periods happen, when we see the return of symptoms, we have treatments now that patients can take as as needed, on demand, when this off period occurs. So an inhaled levodopa is one of them. We have a sublingual apomorphine, and we have an injectable levodopa. Again, these are all injectable apomorphine. We'll be talking about all of these in the on-demand therapies, but again, we're talking about levodopa-based medications for now. This is also one of our levodopa-based medications, and here you can see the reduction in the change in the Unified Parkinson's Disease Rating Scale for patients who got the inhaled levodopa. Again, the 84 milligram dose was the most beneficial. Peak effect at 30 minutes, but you can start to see an improvement already within 10 minutes, and you can see the difference of the patients who received placebo when they had the beginning of an off period. They were able to take it as part of their pivotal trial. We also are looking at subcutaneous carbidopa-levodopa formulations, and there's two major clinical trials occurring, one by AbbVie and one by Neuroderm. And AbbVie uses a belt pump. It's called ABBV 951. Neuroderm is using a patch type pump. It's called ND 0612. And these deliver these subcutaneous carbidopa-levodopa formulations throughout a 24-hour period. And these are currently in clinical trials, and we're waiting to see the results of that. And it's, again, if this becomes beneficial, then you don't need a kind of like a surgical intervention or a G-tube placement. These kind of use kind of very similar technologies that a diabetic insulin pump would use, et cetera. So these are different types of treatments that are being looked at. And there's a lot of excitement. If you can deliver a subcutaneous carbidopa-levodopa, would that be better than popping pills all day? And again, give a more continuous infusion of levodopa, keep those plasma levels more concentrated. Would that also indicate that you would have better motor control? Again, these are still in clinical trials. Non-oral treatment strategies have been looked at. Again, we talked about the subcutaneous pumps. There's also the intrajejunal infusions, like the carbidopa-levodopa enteral suspensions. There's other suspensions looking at carbidopa-levodopa and entacapone. We looked at the inhaled levodopa, so bypassing the gastrointestinal system. A lot of research being done there. We're also looking at apomorphine infusion pumps, and they're available already in Europe. We may see that, especially with the Toledo study. We've seen that as well, so improvement in on-time and off-time, et cetera. We may see that in the early part of 2022. So other things have been tried as well. We have the apomorphine, which is subcutaneous pen with subcutaneous with apomorphine pumps. We're looking at the levodopa-based ones. We'll see there's even a we have rotidogene, which is a patch. There's been some other inhalers besides the levodopa powder. Apomorphine has also been researched. Intranasal rotidogene failed. It's no longer, it's been discontinued in research. So these are some of the non-oral dopaminergic therapies, mostly in research, but we're going to continue to see ways to have more continuous type of delivery and try to see if we can bypass the gastrointestinal system, because that protein interaction, and also just with the gastroparesis and constipation our patients have, that also limits the effect of these medications. So this has been a very thorough type of review of all the dopamine therapies available currently for Parkinson's. You know, I know there's a lot of information here, but to me, this is exciting. This is what makes Parkinson's so special, is that there's multiple therapies that are available for our patients. So it's up to us to let our patients know about the different types of medicines and find the right drug that works for a particular individual. And especially with a lot of these new formulations, we're seeing that a lot of insurance companies don't want to allow our patients to have these, but we see in the clinical trials, when compared to the 1975 formulations, our patients have better control of their disability in the UPDRS. They have more on time, less off time. So it's us as for us as healthcare providers to offer these to our patients and say, hey, the clinical research supports the use of these different agents. So, and we're going to see continued improvement. So it's time to move away from 1975 and jump into 2021 and beyond. There are advances being done in the treatment of Parkinson's. I hope this really kind of opens your mind, see everything that's available for our Parkinson's disease patients, and find the right treatment for each individual. So everybody is different. Just like we started, we got to take a look at the disability the patient has, their comorbidities, what they're going to be able to tolerate, and what type of schedule they can upkeep. And hopefully we'll continue to see improvements throughout this next decade. I think it's going to be very exciting. So hopefully you found this very beneficial. Thank you so much for joining us on this first inaugural Advanced Therapeutics in Movement and Related Disorders, and not your grandmother's dopamine. Hopefully this was enlightening. I hope to see you soon and live and in person in the next Congress. Bye-bye.